So my name is Mary Maluccio. I'm a surgical oncologist, and it's always a good strategy to start with the really intelligent people up front, and then you'll say, boy, surgeons are really simple. So I oversee our multidisciplinary neuroendocrine program in our clinic, and I was asked to talk about the role of surgical resections in the setting of metastatic neuroendocrine tumors. And I agree with David, it is very difficult to see up here. I also have no disclosures. So the objectives of my talk were to review for you the unique aspects of NET that I think to a certain extent have been covered, but that influence how, from a surgical perspective, we help you make decisions regarding surgery. To clarify some of the indications for surgery in the setting of metastatic disease, going over what has really been our programmatic philosophy when it comes to the role of surgery and what is a very multimodality treatment group. And then to set expectations for you on the outcomes from surgical interventions, some of the variables that will be very unique to certain clinical situations that are important to consider prior to jumping into surgery, and then some of the convincing evidence that would drive a more proactive approach to surgery. So some of the unique aspects of NET that influence surgical decision-making are the primary tumor site and the unique complications or issues that come with operating in that part of the body. So the primary tumor site, of which the most common are going to be your lung, intestine, and your pancreas. So I'm going to sort of focus on those primarily because when you're dealing with it in the context of metastatic disease, the approach is very similar regardless of whether or not the mets are from lung, intestine, or pancreas. The potential for symptoms from the primary, of which the intestine is more likely to become symptomatic over a period of time than the pancreas is, and the pancreas is more likely to become symptomatic over time than the lung. Whereas the morbidity associated with the surgery is almost the exact opposite. The intestine is much less likely to have post-surgical complications and morbidity associated with that than the lung, and the pancreas is where we really have to think a little bit more in depth about whether or not the risk is worth the benefit of pancreas surgery. So our programmatic philosophy has been to just recognize the heterogeneity of the patient population. So unlike more common cancers like breast or lung or colon, it's very easy to compartmentalize people into clinical situations for which there's really a relatively straightforward recipe on how we would offer treatment. First line, second line, third line, and where surgery would come into that. So it's difficult in neuroendocrine patients to fit them into a concise box, and so each and every one of you in the group is going to have very unique variables that are going to drive decisions in your case where you may seemingly think that your case is similar to the person next to you, but for a variety of reasons it is not. And so therefore, in our multidisciplinary clinic that David alluded to, we have up to 7 providers that are in that clinic. And so a patient can come in and see either 1 or 7 of the people that are involved in our multidisciplinary program, depending on the unique variables that we think are weighing into decisions in that particular patient. And then we write it all down in a treatment plan that you get in the mail, so that it's kind of like having a strategy written down for you that makes you understand what it is about your case that is driving decisions now. What if happens over the next year, 2 years, 5 years of time, and how we may bring in other modalities along the course of what is a long disease. So we identify those unique variables that drive decisions. Unlike other abdominal cancers, the neuroendocrine cancers are treated over a much longer than average period of time. And so if we were to take a throw in the kitchen sink at diagnosis approach, then you may be living with the consequences of all of that treatment up front for the remainder of your life. We call that survivorship issues. We deal with a lot of that in patients that will live a long time, like after breast surgery and treatment. And so therefore, the timing of treatment has to be taken into consideration over what can be years to decades of life. So we have to know when and how aggressive to be, and that the complications in particular with surgical intervention can weigh heavy over that long period of time, because you may develop a complication that is ongoing, and therefore that post-surgical phase of your life will be different. And then we strive to value the contributions of multiple disciplines, because unlike some of the more common cancers where it's predominantly radiation, medical, and surgical oncology just having to come up like, when am I doing the surgery and when am I giving the chemo? There are so many other providers that are involved in the treatment of neuroendocrine patients that it's really important that we all sort of sit down at the table and come up with some sort of a consensus on what would be our approach to any particular patient. And then we have put that together in what we believe is a very constructive programmatic development. So cancer metastasis paradigm, if you were to think about other types of cancers, is that you have it grow in a primary site, and as it grows, it will cause symptoms. Colon cancer will cause obstruction, bleeding, bloating, and therefore you will go to the doctor and they will focus on that symptom and they will diagnose you with the colon cancer, and then they will look for the extent of disease. Has that cancer spread to regional lymph nodes? And then as part of the extent of disease workup to drive what is the next medical decision, you will see whether or not it has spread outside of the colon. But the driver is usually going to be the primary site. The net metastasis paradigm is very different. You can have a very small primary in the lung, pancreas, or intestine, and that can be asymptomatic over years of your life. It can spread to regional lymph nodes, which can be actually the indicator of the disease, even when it is imaged on a CT scan done for completely different reasons. You could get in a fender bender, and they come and they see something in your mesentery, and that will be the way that someone has their intestinal carcinoid diagnosed. So regional lymph nodes become an area that may or may not be causing symptoms, but would be an indicator that you have the disease. Even more commonly is that it's actually symptoms associated with the metastatic disease that actually brings you to the medical community. It's the flushing, it's the fainting, it's the diarrhea, it's the malabsorption. Other things you're saying, what is wrong with me? Well, that's because it is the metastatic disease, even in the setting of a very small primary. So that it's the management, as David went over, it's the management of the symptoms associated with the metastatic disease, and then sometimes the symptoms associated with the regional disease. And so therefore, that's the reason why we as a multidisciplinary group are saying, do you operate on that person? Do you not operate on the person? Are you really focused on the symptoms associated with the metastatic disease? Because often the surgery to deal with the metastatic disease is far bigger than the surgery to deal with the primary. So I'm going to go over each one of them separately. So intestinal primaries are unique. And they are unique in that they are more than likely to be small. They can be small and they can be multifocal, but they can be small like a pea sitting in your intestine, causing no symptoms whatsoever. They can present as incidental abnormalities on a scan being done for different reasons. They are more likely than other NETs to present with symptoms associated with a neuroendocrine syndrome, and that is because they are more than likely going to be the ones where you are actually presenting with the symptoms of the metastatic disease. And so you can have mass effect because of growth in the mesentery of the small bowel, or you can have very subtle liver function test abnormalities associated with the liver disease. But that intestines are highly likely to be surgically resected. And so why is it that intestinal primaries, even though they are small, unlikely to be symptomatic, why would we be more likely to resect them than something like a pancreas? And the reason that is because the intestines are like a fan. So that if you were to look, this is your colon, and they just splayed it out so it looks like a fan. So you got your colon here, and then you got your spit here. So here's the fan, and all of these blood vessels are all in the handle of the fan. But that the blood supply coming from the center here is coming outward here. So this small little primary right here, which may be completely asymptomatic, as it continues to grow in that area, even if it is growing over a 10-year period of time, will start to encroach upon the blood supply that's coming into the fan. So that if you were to look at the resection required to take out that primary, it's going to be a small area and maybe a little bit of this fan, but that you're going to save all this other stuff. But that if you have mesenteric involvement, like I said, you can see it as an incidental finding on a scan. Once it starts to involve that, over that 10-year period of time, it will slowly start to encroach on more and more of the blood supply. So therefore, we've taken what would have been a very straightforward, kind of low complication rate procedure, and now we're taking more of the fan. You're going to lose more of the intestine. You are more likely to then have symptoms associated with the loss of that intestinal length, only because we said, oh, but it's so small and asymptomatic, we should just leave it. And so because intestines are lower risk procedures and they are more likely to develop symptoms over a long period of time, we do something to try to eliminate, to the extent that we can, you having a problem. Because once it develops up into this area right here, it's a really big problem. You may be asymptomatic here. Here, you hurt every time you eat. Here, simple resection. Here, we're looking at like intestinal transplant. So the spectrum of surgery that's required on the gut can be from very, very small to almost the biggest that we do. So we like to do it when it is small, even if it is asymptomatic. The liver, if you were to look at the liver is actually quite simple. It's like a tree. So it may be difficult to operate on because going through that big hunk of brownness happens to be a bunch of blood vessels. And so the liver can be easy to operate on, and it can be really hard to operate on depending on where the tumors are in the liver. So therefore now we've raised the stakes in terms of the risk benefit of surgery in the liver, but there are clear benefits, and we just have to weigh how much functional loss in the liver are you gonna have in order to eliminate the degree of tumor burden that we are aiming to. The one nice thing about the liver, it is extraordinarily resilient. You can resect up to 2/3 of a normal liver and have that small remnant, almost as big as my fist, grow back over around a 6-week period of time. So as long as we have a line and we don't cross the line beyond which your liver can take, liver surgery as a component of management of metastatic neuroendocrine will always remain on the plate of options that we consider. So if we were to look at two tumors in the liver is divided into segments. There are 8 segments depending on the branching pattern of this vein. So the arteries that David works with are going along with the vein. So his ability to treat a tumor in a very particular area of the liver is almost the same as our ability to operate on a small part of the liver or a big part of the liver, depending on the location relative to the blood vessels. So this one, if you were to see, this is segment 5 and segment 6, but that in order to remove this tumor here, it's literally like being a tree trimmer. You're coming in here, and with an ultrasound, I am finding that branch, and you can take a very small section of the liver, even if the tumor is quite large. So the decision to operate on the liver has a lot to do with how big the tumor is relative to the functional loss of the normal liver substance that's going to come along with the specimen. So if you were to look at this tumor here, I can go in, and I'm going to show you some data in later slides. I can go in and you can get this tumor out and spare all of these branches and these branches and lose very little liver substance. Where if you move that even this far over here, and all of a sudden I have to take this branch here, well, that branch there just took 1/2 of your tree. So liver surgery is where the risk-benefit is often probably debated most often, and really it's a dance between David Agarwal and someone in my position on what it is we need to do to maintain options. So I will tell you that in liver surgery, I am very, very focused on maintaining arterial options because most of his access is all going to be arterial. So surgical intervention was removal of the primary. Resection of disease within the liver, we use what's called substance-sparing resections, meaning that we try to save as much substance as possible. Just as with what David Agarwal described, it is primarily done for symptom control, although I will show you some data to suggest there is a survival benefit. And even though there is no magic to how much the goal for removal is, I think that we are, as a net community, saying that if you cannot remove greater than 75% of the tumor burden in the liver, you may have to reassess whether or not it is worth the risk. And then we have a way at IU of looking at the risk-benefit using functional imaging, meaning that we can look using functional imaging similarly to how David looks at how much of the liver will be treated if he were to treat a particular artery. We can look and say, how much, if I resect from here, how much actual function will that patient be losing? So then it comes to the pancreas, or what we call the peripancreatic area. And the reason why this is important is that when you operate on the pancreas, there are very unique issues that you can have. The pancreas is not resilient like the liver. Complications associated with pancreas surgery can live with you over months to years of your life. So depending on the location and the type of tumor that we have, we may choose to operate, we may choose to treat liver, wait on operation, or we may say that we are unlikely to ever choose operation because the risks of complications are too high. So if you were to look at this is called your duodenum, and there is a portion of your intestine that's only around a foot long, but it can harbor carcinoids, it can harbor gastronomas, it can harbor very small neuroendocrine tumors. But that in order to resect areas of this, it all has a common blood supply. So therefore, once you start intervening in there, you've got a whole lot of traffic that is coming in and converging right into this area. And so you have to be very careful that if you're going to do a limited resection, you got to keep everything else intact. But that if you're doing a major resection, you got to take it all out, and then you got to hook it all back to the intestine. So really small carcinoid tumors in the duodenum are now actually approached with endoscopic techniques. We have very talented gastroenterologists that can go down there and they do these endomucosal resections. And as long as it's in a decent location and it's below a certain size, it's really almost like they do in colon surgery, taking out a polyp. And so when you're trying to take out what may be a small primary that it may, if it were to grow in that area over the same 10 years of time, it may be best if we just remove it, but that in the duodenum, why would I take out this whole big chunk if I could do it with a very limited technique while it is still small? If you move to, I'm going to jump to the tail of the pancreas here. So the pancreas is like a fish, it is cupped within this duodenum, and then these are the blood vessels that are literally going to the entirety of your small bowel. So if you have something in the tail of the fish, then the only thing that is an innocent bystander is often the spleen. And so depending on the size, depending on, like Dr. Anthony said, depending on the aggressivity of the tumor, if it's low grade or really not even, it's quite bland, not even having any sort of invasive characteristics, you can then try to enucleate it out of the tail of the pancreas by just coming around it and almost delivering it like a marble out of the background. Or you can take out the tail of the pancreas and spare the spleen, or there are some circumstances where it's going to be larger, has some invasive components to it, and that we have to sacrifice the spleen. But for the most part, in the adult population, and if we can give the vaccines up front, that is of very little consequence to most adults. So a distal pancreatectomy is also a quite reasonable approach to a neuroendocrine tumor in the tail of the pancreas. Where we really do a lot of debating is when it's in the head of the fish, because the morbidity associated with that case, which I think I have on the next slide. I lost my clicker thing. Next slide. Is if you go into go to the next slide first, and then I'll go back to this one. So if you go into the head of the fish, there are very unique issues with that operation. So that's called a Whipple procedure. And the Whipple procedure comes with a 5% major complication rate. So when we're describing that to patients, it means that will a complication from this operation cause you to have problems over a good length of time? And that could be years to the rest of your life. Minor complications are almost 50-50, and that the minor complications also have a chance of being ongoing. So it's not like you say, oh, it's a minor complication, we're going to put this drain in, and then 2 weeks later you're going to be fine, and then you're going to be, without any symptoms. So the problem with the Whipple and why we debate it is that it does actually impact how we manage liver metastases in the future. You have a higher likelihood of having problems when we treat the metastatic disease in the setting of a Whipple procedure. And so we will often hold on doing a proximal pancreatectomy where I take out the head of the fish. We will hold on that until we're pretty certain that there is going to be a survival benefit, and therefore the risk, the investment that you're making in that case is worth it. So on the other hand, a distal subtotal pancreatectomy, which takes out the end, plus or minus the splenectomy, the major complication rate is quite low. The minor complication rate is still around 30%, but it is highly unlikely to be ongoing. So we can get almost everybody through a distal pancreatectomy, and 2 weeks or a month, you won't have any issues. So will you go back to the previous slide? So this was just to cover the endoscopic transmucosal. It's very low risk. It is limited for the most part to very well differentiated low-grade carcinoids. Now, depending on the location of the tumor, because you've got bile ducts, you've got different ducts coming into that C loop of your duodenum, so that the location will often mean they can't just suck it up into that scope and do a transmucosal resection. So then we have to go in and we make a hole in the duodenum. We actually put little stents up into those ducts to show us where they are, and then resect the tumor off of it. Still relatively low risk, but that it has to be done open, but it's far less complicated than the Whipple procedure. And then the enucleation seems like a really great option, but that if we could manage how we deal with what can be not really problematic pancreatic leaks, but kind of a nuisance pancreatic leaks, because you are enucleating or coring that tumor out of a relatively soft pancreas, and the pancreas does not like that. Okay, so you can go on to the next one, and then the next one. So now I was just going to say that, so I think this is Palmieri's data, is that there is convincing evidence that resecting the primary and even resecting the metastatic disease is associated with a survival benefit. So that Although programmatically, I feel like we have taken a somewhat more conservative approach to it. I was going to end by showing around 4 actual data slides because I think that although I can't imagine being as aggressive as the Ochsner people are down in Louisiana, I do think that we probably have room to be somewhat more aggressive. So the improved survival with resection of the primary, this was what Dr. Anthony showed, which is there clearly is a benefit to survival, but that where each patient falls into that is really the discussion that we're having, because these are very highly selected patients. It wasn't like we did a randomized trial and we could easily say, okay, we're going to resect you and not resect you, and then we showed this difference. It was that for a lot of very good reasons, we resected some people, and for equally good reasons, we did not resect other people, but it panned out that the people that underwent resection did better. And then there are several consequences of not resecting the primary. And so this goes a little bit into what Dr. Anthony was talking about in terms of understanding the aggressivity of the primary and the likelihood of you either developing symptoms or it becoming a life-limiting problem for you. So those are the variables that talk about the grade of the tumor, the size of the tumor, the pace of growth of the tumor. And if you have a pace of growth that is out of proportion to the metastatic disease that is causing you your symptoms, well, then we do have to address the primary, even if it's the Whipple, even if it's the total gastrectomy. But once again, we're doing that by selecting patients that are clearly or more clearly going to benefit from that aggressive surgery. And so this is the data from Ochsner, of which Elaine, if any of you wanted these couple of papers that just really go into some of the evidence that supports probably a more aggressive surgical approach than most centers do in the US, our program director, Elaine, would be able to get those papers for you. So this was their institutional data. And I suppose the one problem with interpreting surgical data is that we tend to have our own institutional preferences. We have our own institutional strengths. And so therefore, it's really saying, if you go down to Louisiana into this, then this is what they can offer you. Whereas most data that drives medical decisions on a bigger scale are when you would be able to walk into any center of excellence for this disease and we'd all be talking the same languages. So this goes into a lot of patient selection and how they chose it. But that when you have 1,500 people show up in Louisiana and you have that denominator, I think that there's a lot of richness to that data in what is possible. So then when you look at centers like ours that don't have 1,500 patients but have the same technical expertise to do everything that they're doing, it's really us just defining what that line is and how we select patients into it. So this is their survival looking at just the low-grade, slow-growing, indolent that Dr. Anthony described, small bowel midgut carcinoids. And they felt that they showed that with a long disease interval and an aggressive surgical approach, they had very good long-term survivals into the 20 years, of which that was twice the national average at almost all time points. I would say that our medical oncologists, for the most part at IU, have been very conservative on the midgut carcinoids because they're saying, you know what, doing nothing is as beneficial as doing something, so why don't you just hold the phone, don't be doing anything aggressive until we really see that there's a clear indication. I think that based on talking to the Ochsner people and looking at this, I think we're going to have to come up with something that's a little bit more in the middle. And then this is when they looked at aggressive surgical approaches to neuroendocrine tumors when they were doing cytoreduction, meaning that their goal was not necessarily to eliminate all measurable disease, which is usually our surgical endpoint, but highly selected patients where surgery was clearly the most likely to give us the endpoint, meaning symptom control, get rid of the bulk of the disease, get rid of something that is the potential to cause significant problems. And it's really hard to argue when someone's coming with 1,000 cases under their belt, because I think that you have dealt with any of the variability that comes with this unique patient population. And so this was just the distribution so that you can understand where you would potentially fall into it. The vast majority are pancreas and small bowel. That's usually the patients that are going to surgery. And then their survival results were excellent. And once again, if you were to look at almost any smaller surgical series in the United States of America, these survivals are longer. And so really, I respect a lot of what they have done. I think that their reputation is a bit that they are beyond the pale on surgical aggressivity, but I have to admit, they don't have high complication rates. The patients do well, and then I think their other thing is that when they did their performance status, meaning their ability to have someone feel better and have a better quality of life after we've just done this major debulking surgery, they were even able to show that on average, the post-operative quality of life was better. So I think that with highly selected patients, you can be surgically aggressive and still have good outcomes, but that where you fit and the timing of that surgery is super important. And that's all. Thank you.